I want to jump into another question for the panel, and that is, how many have tried ivermectin? Is that a treatment that we should put in this category? Do we need a systemic or topical treatment with ivermectin, or is lotilaner enough? And I'm going to go through the lotilaner data in a little bit, but what are your thoughts, Eric or Paul, or anyone on the panel?
Yeah, I'll start here. Paul can chime in as well. But the idea of using a systemic medication that's associated with side effects to treat a localized disease when you have a topical therapy that's better is silly. And I can't even think of a single reason why anyone would want to use oral ivermectin any longer. It's unfathomable to consider using this. It's a systemic drug, and the drug concentrations don't get nearly as well into the tissue of the lid margins as just applying it topically. It's like using an oral antibiotic to treat a conjunctivitis. It just doesn't make sense.
And it's
Yeah,
not approved. And it's not approved for this as well. I mean, specifically, we don't have an FDA approval for this. But go ahead, Paul. Sorry.
no, that was a great comment too, Marjan. I know I'm really agreeing with Eric on this one. He said it perfectly. I have prescribed it prior to XDEMVY. We didn't have a lot of options. I had some patients that were that affected them almost psychologically when they got a diagnosis that involved mites. So I was willing to do whatever we had to do. But you have to figure out the dosing per kilogram. There's a lot of complexity to it. It's systemic. You're going to have side effects in the whole body. You're trying to treat a local treatment when you have a drop. I don't think there's a place for it now. I think you bring in a lot of risk, a lot of time, a lot of calculations, a lot of side effects and not necessarily the efficacy you'd want to have. And again, it's, you said, Marjan, it's a general antiparasitic. It's an antimalarial, therapy. That is not specific like lotilaner, which of course is topical, targeting Demodex in the ocular surface. So I'm with Eric. I don't think there's a place for it. I don't think there's a place for topical either. You can have like a cilantro, which is a topical ivermectin. You're not going to put that in the eyes. It's a cream. I think you're going to have all kinds of problems trying to get it near there. Toxicity is not indicated for the eyes, not indicated for Demodex blepharitis, especially. And so even if you went topical, as we just talked about how oral wouldn't be a good suggestion, even topical, I don't think is applicable or safe. And it's not going to you're not going to place it at the site where you need it without it getting in the eye, which would cause all kinds of trouble. And it's never been studied for this, like you said, either.
And so I'd like to ask Jeff, maybe you can comment, because there are some states that have required patients to do ivermectin before lotilaner, and it sort of doesn't make sense to us, but can you shed some light on that?
Well, I think there's still a high level of educational need with this particular disease state. Ivermectin does not make sense. I was going to say, and I was going to ask you a question kind of along these lines, is, I will admit, so I've been in managed care in the payer space as a pharmacist for, a little over 20 years, and I don't recall ever talking about this disease state. This was something that I was completely unfamiliar with prior to the XDEMVY approval, and then we had to educate ourselves on the disease state, obviously, with that approval. Similar with ivermectin. We never talked about ivermectin. I mean, it actually popped up early on in COVID, interestingly enough. That's kind of where it kind of popped back up on the radar screen. So there's definitely unmet need here. Once you dig into that, I don't think ivermectin makes any sense. But my question was, and I think this is more for the payer colleagues who are going to be listening to this, because I know there's some access questions that we probably are going to get into, is, what are the clinical consequences of this? Because, we've seen, in our research, with the drug, we've seen prevalence anywhere from 15 to 70%. We've heard, the colleagues on this call saying it, the majority of patients have it. If it's that prevalent and we've never heard about it, what are the clinical consequences? Is there a gradation here? Because, should we be focusing on, using our resources to treat a subpopulation or everybody, because employers and payers are a little concerned about the high prevalence and the cost of this drug and who the appropriate patient is. So I guess the main question is, my question is, what is the clinical consequences of this, and who's appropriate to treat? And when we dig into that and we educate ourselves, I don't think ivermectin has a role. So
that's well said. I love this question. I'll jump in quickly because I let Eric and Derrick chime in as well, and Marjan. But this has always been kind of my main thing for patients too, and the fact that we have been treating this in my clinic for a long time. It's kind of been my little ace in the hole that, hey, we recognize Demodex. I learned about it from Donald Korb over 15 years ago. I was always looking for it and I was amazed at the prevalence. Tea tree was toxic, it was strong, was high concentration. Ivermectin, we talked about the perils of that. But I always would tell patients, even those percentage that are asymptomatic, that the reason we need to treat this is because of the long-term sequelae. When I see a patient coming into my clinic, and we do meibography, obviously, on every patient because it's an ocular surface disease referral clinic. And so I'm looking at their meibography, and I'm seeing they're down to like 6 glands. They started with 48, 43, depending on the patient, and they're down to like 6. There's typically very few conditions that'll do that, but one of the most common is Demodex. And I'll look at their eyelids, and it'll be like grade 3 Demodex blepharitis. So while that is anecdotal, I've seen it enough over the last 20 years, 2 decades of this, to recognize that there is an association to it, it has to be playing a role with the inflammation. Eric described how brevis gets in the meibomian glands, which is the other form. Those are the glands that are starting to show a lot of atrophy. So for me, the biggest detriment is the severe level of ocular surface disease it can cause, which is an evaporative form. From a cosmetic standpoint, patients complain about their brittle lashes, their loss of lashes, thinning of lashes, multiple hordeola or chalasia, recurrent styes, I guess as patients would put it. You look at that we call a scalloped lid margin, where you start to get that really irregular eyelid from atrophy, which would apply here as well, and just the overall psychosocial aspects that play a role when you have chronic red eyes, bad tear film, severe dry eye, and all those components that ensue over time. So yeah, for me, it was always an easy discussion, even an asymptomatic patient, because I could relay to them the risks of not treating.
Okay, no, that's helpful, and I think I would make that a priority moving forward, especially if you're talking about coverage and access, because again, I think a lot of people are looking at this and saying, everybody has this, we've never heard about it. Is it really a problem? Is it more cosmetic? Does it cause, if we don't treat it, is it going to cause problems? And I don't think that's well understood. So I think that's the unmet need, is the time frame and what those clinical consequences are. And if we don't treat, we don't pay for this, then what is that going to result in, both clinically and financially down the road?
So from a payer perspective, I would make the strong argument that the cost effectiveness of using lotilaner to treat Demodex blepharitis is extremely high. We know it works very effectively, but the alternative of not using it is that many of these patients who have Demodex blepharitis are being treated for dry eye with medications that are used for 12 months at a time. And the cost of using an immunomodulator such as Restasis or Xiidra, wonderful medications for these patients, is dramatically higher than the cost of using lotilaner. Lotilaner is one therapy, 6 weeks, and the studies show that the effect lasts for a full year. So that you're getting an effective therapy for ocular surface disease that lasts for an entire year with one prescription of medication. The alternative for many of these patients is 12 prescriptions prescribed of medications that are more expensive over the course of a year. So I'll make the very strong statement that use of lotilaner saves payers money.